ahead and get started. If anybody's new who's joining us, just by way of introduction, my name's Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota. And we've been doing these webinar series on various geriatric principles of care. Most of them are revolved around what we call the geriatric 4Ms of what matters: mentation, mobility, and medications. Some people add a fifth M in there. They call it medical complexity. And that's legitimate to consider the 5Ms, but we try to practice our primary care of older adults through these 4Ms. And then we're also interested in geriatric syndromes. And that's the point for today's presentation, is to walk through the issue of urinary incontinence with the older adult. So can I have the next slide, please? So what we'd like to understand today is the demographics and the different forms of urinary incontinence, how we categorize them. We want to talk about the anatomical changes that occur with age that predispose towards urinary tract issues. And then we want to walk through both the assessment and the management plan of urinary incontinence, which quite honestly has evolved over the years. And what I learned as a fellow in geriatric medicine is not so much the way we evaluate urinary tract issues or lower urinary tract system issues that we once did. So there's been some updating of our approaches. Next slide, please. So what we want to cover are, as mentioned, the demographics. We want to look at the risk factors for incontinence, a little bit of the aging pathophysiology, and then get into the evaluation and treatment. I will not be talking about nursing homes, catheters, and catheter care during this session. Okay, so there's a lot of urinary incontinence out there in the community. So 25% have some form of urinary incontinence. That really bumps up considerably, where 2/3 of long-term care residents have some form of incontinence. Age in itself is a risk factor. There is a gender difference. Women are affected more than men. And then interestingly, at the age of 80, it's basically gender equality for urinary incontinence. And I think most of us know, what the conditions are for women being predisposed to urinary incontinence, and we'll go over those just as a review shortly here. Next slide. The impact of urinary incontinence can be physical, causing things like dermatitis, either nonspecific or infectious dermatitis, which would be called cellulitis. It can also lead to pressure ulcers, as well as urinary tract infections. I'm sorry, I didn't finish. It's good I'm getting an anticipatory slide change. I appreciate that. But anyways, let me just finish this, where sleep deprivation because of what we call nocturia can occur. And then as a result of getting to the bathroom a little too quickly or trying to rush getting to the bathroom, you can have falls, oftentimes with fractures. And it can also cause problems with sexual dysfunction, which is a whole nother topic of discussion for the sex in the older adult. And then the issues with urinary incontinence cause psychosocial issues, depression, social withdrawal, the number of people that don't want to go out because, they're concerned about being incontinent. So it impairs their quality of life. Now, next slide, please. The risk factors, in addition to age for urinary incontinence, are being overweight, functional impairment, so not being able to get around or transfer. Memory loss is another reason. Medications, particularly diuretics, can predispose to urinary incontinence. Diabetes, both as a result of uncontrolled blood sugars and some other pathophysiologic changes in the urinary tract system due to diabetes. And then generally the environmental barriers to toileting, and these are more pronounced in the long-term care setting. Next slide, please. So there's a lot of illnesses, chronic diseases that can either be the direct result of urinary incontinence or make it worse. And these include mood disorders, both depression and anxiety. Alcoholism can be a big problem for urinary incontinence, both in terms of its effect on the brain as well as on the bladder control in general. Chronic cough, so if you have a reaction to, like, say, an ACE inhibitor, or, you can even think post-COVID cough, that these can precipitate stress incontinence. Heart failure because of the high level diuretics, and so forth, as we can see on the list here. On the right side of the list, you see neurodegenerative disorders, you see osteoarthritis, rheumatoid arthritis, and then the final one there with B12 deficiency. Although I don't think providers generally think that if somebody's incontinent that they're B12 deficient. So it's kind of an interesting link to think about that. I would say I'm seeing about anywhere from 1 out of 10 to 1 out of 5 patients thereabouts who have some form of either low B12 or frank B12 deficiency, and similar observations with vitamin D. And I don't know whether that's kind of a recent observation. I don't know if it's because of the COVID recovery that people are having and they become vitamin deficient or not. I really don't know. It's just kind of a interesting observation that as we order more and more of the vitamin tests, we're seeing deficiencies in older adults. Next slide, please. I mentioned medications such as water pills and diuretics that can cause urinary incontinence, but you can see there's a whole list here of just about everything that treats high blood pressure can cause urinary incontinence. Next slide, please. So in thinking about the physiology of aging, some of the things that occurs that you have a contraction, so the bladder has less contractibility, and it also kind of has these undulating, pulsating contractions or spontaneous contractions. If it happens in the heart, it's called atrial fibrillation. Sometimes people call this urinary tract bladder fibrillation. But again, it's these muscle, it's kind of like a Charlie horse, if you will, small Charlie horses in the bladder. And there's also a shift in the how the urine is outputted. And so that's occurs later in the day and more towards the night. And what we'll talk about is having people just before they go to bed is to elevate their feet prior to going to bed to try and reduce the nocturia, because the lower extremities tend to accumulate a lot more water because of venous insufficiency with age. So as a result of the less bladder contraction, there's also less bladder capacity. So the bladder kind of contracts and shrinks. And much like the heart does, by the way, the heart also shrinks in some respect with its ability to accept blood. And so the volume is not as great. And then there's some external issues such as decreased urethral closure pressure. And this is more prominent in women due to mucosal atrophy. And then conversely with men, the association with benign prostatic hypertrophy can cause changes in bladder control. Next slide. So if we try to link the types of incontinence with the physiology, you can see that there's 4 different versions. And these are all important to know because the treatment may be a little bit different for each one. So we call urge incontinence, the sense of having to go to the bathroom and having to get there like right now. That's called urge incontinence. And it's often due to the muscle of the bladder, the detrusor muscle being overactive. Another term for that is uninhibited bladder contractions. And again, it's part of that undulating bladder activity, which can be provoked at small volumes. And that's why oftentimes we say that if the older adult can hold and just kind of get through those contractions, that the bladder then will start to expand and settle down. But it takes a few minutes, and if it feels like you got to go, you got to go. And it takes some biofeedback or some training to overcome that sensation of having to go. Now, conversely, there's stress incontinence. That's where there's impairment of the urethral sphincter support or its closure. And those are the types of incontinence episodes that we attribute to either a cough, squatting, jumping, climbing stairs, anything that increases intra-abdominal pressure. And then mixed incontinence is really both. You get these undulating bladder contractions, and then you have a incompetent sphincter. Urethral sphincter is incompetent, and between the two, you get a combination of both stress and urge incontinence. And then finally, there's overflow incontinence, where the bladder just kind of becomes flaccid. It's either because of neurologic issues such as a stroke, or outlet obstruction that causes a distended bladder that becomes weak. And so that's basically underactivity of the muscle or a weak muscle, and that would be called overflow incontinence. And it's most frequently observed as a distended bladder on ultrasound. Next slide, please. So in terms of urge incontinence or detrusor overactivity, it's associated with age, not a surprise there. There's no clear physiologic reason for it. It's so we call it idiopathic. It can occur with lesions that occur from stroke or even cervical stenosis, so the tightening of the spinal cord, that inhibit central pathways for controlling bladder. And then it can also be associated with bladder outlet obstructions that might occur from kidney stones that have migrated down into the bladder. Of course, you can get bladder stones also. So that's usually why we look for urine analysis for hematuria or red blood cells in the urine. And then some infections, particularly yeast-related infections that create these fungal balls, if you will. Those can cause outlet obstruction, and both benign and malignant tumors. Next slide, please. Excuse me. In terms of stress incontinence, the leakage can be due to the damage of the pelvic floor. So that's where the Kegel exercises always come into play. So it's basically the urethral opening cannot sufficiently compress the urethra in reference to the intra-abdominal pressure. And you can also get just sphincter failure. So either, again, because of mucosal atrophy, there may have been a surgical procedure, either urethral or gynecologic, that can cause sphincter failure. Okay, next slide, please. So with stress incontinence, I mentioned about the cough, which can also trigger this detrusor instability. And usually the leakage occurs a little bit after the cough, and so that would be indicative of stress incontinence. And once the urine is spilled, it's hard to prevent it from stopping. And again, it's often part of a picture of what we call mixed urinary incontinence with both urge and stress elements. Next slide, please. So this flaccid underactive bladder leads to or is associated with detrusor underactivity. And the outlet obstruction, such as BPH, can often cause this. In women, there might be a cystocele. Okay, so that's when the vaginal vault exudes outwards. And, so sometimes you can diagnose this on a gynecologic exam. You can ask the older woman to bear down, and you'll see a pushing out of the vaginal mucosa through the vaginal opening. And then you can grade them as a 0, 1, 2, 3, or 4. And that's where sometimes the pessaries are being used to prevent the uterine prolapse. The other thing that I didn't mention here is that sometimes a fecal bolus is, so if somebody's constipated and they get a large fecal bolus in the rectum, that can cause the same thing. It can cause a outlet obstruction to the bladder in women in particular, because it pushes the bladder over and then it kinks as a result, creating an anatomic blockage. So again, constipation has to be thought about as a potential etiology for urinary incontinence. Next slide, please. So the bladder muscle becomes underactive because of the blockage that causes the smooth muscle to get damaged, and then it becomes fibrotic. Sometimes that's exacerbated by peripheral neuropathies that such as diabetes, and here's where the B12 comes in. I quite honestly don't see a lot of bladder issues with B12 deficiency, but again, I may not be thinking about it enough. So that's just kind of my perspective. And then also alcoholism is a direct toxin to nerve activity. And of course, any damage to the spinal cord, either from trajectories, including bullets, blunt trauma, falling down off of a ladder, any number of these things, falling off of farm equipment. All these can cause contusions and spinal cord damage, leading to this pathway being disrupted that controls the bladder function. Next slide, please. So nighttime urination is called nocturia. So nocturnal polyuria, meaning frequent urination, is usually described as something that occurs when at least a third or more of your total 24-hour urine output occurs at the nighttime. So it's kind of like a 2 to 1, 1 to 2 ratio. This nocturia occurs in the evening, and a lot of times it'll be associated with caffeinated beverages, alcohol. And just remember that caffeinated beverages, as we get older, the caffeine is sustained for a full 24 hours in the older adult. So it's not like you have a drink of, and you get your caffeine buzz and then it just kind of goes away. That caffeine stays with you for quite a while. The other reason for nocturnal edema or nocturnal urination is pedal edema. And so remember I was saying, keep your feet elevated. That's in part because of the venous stasis, causes pooling of the blood and fluids. And therefore, when you lie down, they get recirculated. The kidneys see them. They say you've got too much water on board, and they pass it out through the urine. Something like heart failure causes a similar situation where there's water overload. The kidneys sense that, and then they start producing more urine. And of course, that will be compounded by the use of diuretics for in the cases of heart failure. Obstructive sleep apnea, for reasons that are unknown to me, are also associated with nocturia. And of course, that causes a lot of problems with, a restful sleep because you're taking off the mask. And then, if you are using a CPAP, and then you got to go to the bathroom, and then you got to put the mask back on and try and get back to sleep. Yeah, you can understand the cycle, that goes on with that. Next slide, please. So as mentioned, the nocturia can cause sleep disturbances, and these are all associated with a variety of conditions. Just probably the one that we haven't talked about is restless leg syndrome, which has various degrees, and then you add medications for the restless leg syndrome, and it can cause bladder outlet obstruction. So you're just kind of compounding things. So one thing feeds off the other, resulting in either worsening of the nocturia or the amount of urine that you're putting out. Next slide, please. So for nocturia, there's issues with the lower urinary tract that are compounded by BPH, for example, which both pushes up on the bladder, causing a smaller bladder volume, and it also blocks the bladder emptying, so you have more retained urine. And for some people, typically the cutoff for retained urine is over 200 milliliters, which I guess is about, 2/5 sizes of volume. And but that's still a lot of urine, right? So the bladder capacity is, under a liter. So you're always talking about a quarter to a fifth of the bladder being, used up, if you will, by things like prostatic hypertrophy. Next slide. So I'd like to move towards the assessment of urinary incontinence. In a geriatric practice, we should be, I don't know if we always do, screen and ask patients if they have any problems with not getting to the bathroom on time or loss of urine. It's kind of an embarrassing topic for most people. So they're not going to volunteer that they wear pads or that they have stress incontinence. So that's why it's important for providers to just routinely ask them. Probably this is best done during the annual wellness exam, which we're trying to promote, as a regular activity. I'd say that 90% of most people don't get their annual wellness exam, for Medicare beneficiaries, which is really too bad because it's free and, you can get a lot of helpful information from there. In terms of the physical exam, certainly you want to look at the heart, make sure there's no overt issues of heart failure, abdominal hernias, checking for fecal content, so doing a rectal exam should be an important component of the workup for urinary incontinence. And then looking for different muscle issues, neurologic issues, and as well as doing a GU exam. And that's always, I don't know, whether it's proven that a genital urinary exam is always going to reveal the etiology of urinary incontinence. But, something simply as looking for vaginal prolapse, for example, in women, that might be a good indicator as to why the urinary incontinence is occurring. In terms of testing, the best test is a urine analysis that helps identify spillover of sugar, bacteria, bleeding, so the whole issue of stones with outlet obstruction, and so forth. We do in my clinic, in the geriatric clinic where I'm at Sanford and Fargo, we do post-void residual volumes. We have a little ultrasound machine that we use. Urodynamics, where they place a catheter into the bladder and then just keep adding 50 cc's of normal saline, and then with a manometer measuring the intra-bladder pressures. That's not being that's I kind of grew up as a geriatrician with that kind of testing. I don't think people do it so much anymore because it's pretty much was meant to look for uninhibited bladder contractions, and just about everybody has them. So all these tests tend to be positive. So why do a test that is going to be positive? And then doing cystoscopy is a diagnostic test of last resort, and is probably related to if there's a suspicion of bladder stones or tumors, for example, or strictures. Okay, next slide, please. So when you ask, the patient, so here's some questions here. Do you have any problems with bladder control? It's pretty non-threatening, non-embarrassing. So do you have any problems with bladder control, or do you always make it to the bathroom on time? And again, that urge incontinence is often associated with that suddenness of I gotta go, and it's like right now. And then finally, have you ever leaked urine? So those are the three questions that for self-reporting of urinary incontinence. Okay, next slide, please. So if somebody says, yeah, I have problems with urinary, continence, I lose urine when I run to the bathroom. So here's some of the questions that we want to ask. So for stress incontinence, if some sort of weightlifting, lifting packages, jogging, even walking, if that causes urinary leakage, then you would probably align that or consider stress urinary incontinence as the reason for the problem. And then that whole thing of urgency. So we call it urge urinary incontinence. That's where, you got to get to the bathroom like right now. So if they answer that, they likely have urge incontinence. Next slide. So if it turns out that they have a sense of urgency, that they have to get to the bathroom like really fast, and they also have episodes where they leak urine with a cough or with physical activity, that would be considered a mixed urinary incontinence episode. And then everything else would fall under all other, and that is most likely to be bladder outlet obstruction incontinence. Next slide. So as part of the history, we want to really get down all the elements of when does it occur, how often does it occur, can you give an estimate of how much volume, is it large or small, and then the things that make it better or make it worse. It's much like we ask about pain, where does it start, where does it go, and so forth. Importantly, you want to find out how much fluid intake the person's taking. If they say they're taking 10 bottled waters a day, you might have a clue as to why they're incontinent. Some of the things that we need to think about are called red flag symptoms. And so if somebody suddenly becomes incontinent, all of a sudden, that's a red flag. Anything that's associated with pain typically is a red flag, and hematuria. So some of these we would get on physical exam, or by history, or by testing such as a urine analysis. And then I would also just point out that last point is that bladder incontinence, both in particular if it's in combination of urine and bowel incontinence, that's really a spinal cord lesion until proven otherwise. So those typically get an emergence MRI scan or CT spine scan. Next slide, please. In the review for urinary incontinence, we want to look at medical conditions like heart failure and whether they're controlled or not. So if they've gained 5 pounds of weight with heart failure, then that's probably a likelihood that they're not well controlled, and that's probably why they're urinating frequently. Certainly, you want to look at the medications that are associated with urinary incontinence, particularly with the diuretics. Sometimes we just have to adjust the diuretics, or sometimes we have to eliminate the diuretic for some alternative therapies. And importantly, and we don't always do this in our geriatrics clinic, and we probably need to do a better job of this, is to just ask how much are they bothered by the urinary incontinence, and has it had any influence on their life? Because obviously that's what matters to the patient. And if they say, oh, I used to play pinochle every twice a week, and now I'm not going anymore because I can't get to the bathroom, it's just embarrassing to ask to go to the bathroom. Well, there you go. You found out something that matters to the older adult, and by addressing and you would ask, I said, well, if we fix the bladder problem for you or made it less of a problem, would that help you? And if they say, yeah, oh, yeah, then I go back to playing cards. Then good enough. You know, that's then aligning care and treatment modalities with what matters. And we'll see what the issues are with treatment, because not one size fits all here. Next slide, please. So in terms, excuse me, I've been talking all day, so I've got a little bit of a frog in my throat. The general approach to the physical exam is to do memory testing, right? Because remember, dementia is associated with urinary incontinence. You want to look to see if there's any issues with transfer and walking ability. So slow gait speed, for example, might be associated with urinary incontinence for a couple of reasons. One is that slow gait speed is associated with cognitive impairment. Slow gait speed is also associated with low functional status. And so those two in themselves, gait speed may be an indicator of incontinence. And of course, just not getting to the bathroom on time because you're too slow could be another reason. In terms of the abdominal exam, you can do a bladder scan, is what we do. The old-fashioned way is to percuss up from the pubic symphysis to the umbilicus. And by doing that, you can hear changes in percussibility, and that can indicate a distended bladder. And then in terms of neurologic tests, we'll talk a little bit about the sacral cord, sacral reflexes. Again, this is requiring a physical exam where the sun don't shine, and we'll show you those in the next slide here. So basically, testing the sacral reflexes is that you want to look for anal wink. So there's the two ways to do that. One is by touching the rectal area, and you should get a contraction. The other one is called the bulbal cavernosus response. And so you just very gently stroke the either the penile glands or the clitoris, and that will cause, again, also an anal wink. So you have to be in a position to observe what happens to the anal sphincter with those maneuvers. Next slide, please. I'd mentioned about the digital rectal exam. So that's important to check for masses and pretty much a fecal bolus that might be hard and identifying impaction. Usually these are in sedentary older adults, but it can also occur in patients like with Parkinson's disease or autonomic neuropathies. In terms of the digital rectal exam for men, you're looking for large prostates, prostatic nodules, firmness. Digital rectal exams are still the primary recommendation for identifying prostatic cancer. However, it's not anywhere near 100% in its sensitivity. And a lot of that has to do with the reach of the prostate. You can only get, for most average finger lengths of providers, you can only get about halfway up to feel the prostate. And so you're obviously missing everything that's north of that equator zone there. So that's why things like ultrasounds are more valuable. And then in the uncircumcised male, you want to check for closures like phimosis or partial blockages, inflammation that sometimes can come as a result of the foreskin, usually yeast infections in the older adult, but sometimes just because of ongoing fibrosis of tissue. So as we get older, tissue tends to become firmer or harder. And so too, in terms of the uncircumcised penis, you can get the meatal opening, which has become fibrosed. In women, you're looking for any type of lesions and scarring. So a lot of times, and mostly what you'll find is atrophy. And so prescription for topical estrogens is often empirically done, whether you do the exam or not, because that's often a highly correlated with urinary incontinence in the older adult woman. And then also looking for pelvic organ prolapse. So that's, where the vaginal wall extrudes with intra-abdominal pressure. So, you have the individual in the gynecologic lithotomy position. You ask them just to bear down, and you watch to see if the vaginal mucosa pushes out between the labial folds or not. Next slide, please. Oh, so this is a test. I can honestly say I don't do this as much as I should, but basically you try and get the older adult to drink, a glass or more of water, making sure that the bladder is full, and then in a relaxed situation, you ask them to do a cough, and then you watch if there's any loss of urine. Next slide, please. So urine analysis is the go-to test for urinary incontinence. Having bacteria in the urine does not necessarily mean you have a urinary tract infection. And so the recommendation is not to treat that. For people that have recurrent urinary tract infections, it's now even becoming recommended that even if they have high levels of bacteria and white blood cells that under any circumstances, diagnostically would represent a urinary tract infection, that not even be treated. And the reason for that is that there's new thinking that in some people that the residential bacteria are very similar to what happens in residential gut bacteria. And so that the treatment just ends up creating drug resistance organisms that then themselves can become pathogenic. So again, we're kind of in a transition period where unless there's some overt symptoms of urinary frequency, tenderness, with urination, burning, fever, that unless those symptoms are there, that you don't necessarily treat the urine analysis findings. That said, I'm still not quite certain about these new recommendations with relationship to falls in the older adult, because it's often been found that subclinical or asymptomatic bladder problems or low symptomatic bladder problems can be associated with falls. And so that's my only caveat for the recommendations, what they call LUTS, L-U-T-S, lower urinary tract symptoms, that you may end up having to treat empirically a presumed bladder infection when somebody has a fall. Next slide, please. It's important to ask the patient for a bladder diary that identifies the time of day, night, what they were doing, and the type of, so you can figure out what kind of incontinence it is. This bladder diary then becomes helpful for your treatment interventions, because then you go back and you compare the number of hits, the number of frequencies, that the patient encountered, to see if your therapy, whether it be medication, whether it be behavioral biofeedback, or just simple Kegel exercises. That's how you go back and figure out whether you made a difference or not. Next slide, please. In terms of the testing for the bladder scan, for the post-void residual, it's not recommended as a usual routine thing to do, unless you have these issues with either constipation, history of urinary tract retention, something neurologically going on, which includes dementia, by the way. So dementia, particularly Alzheimer's, and even more so with Parkinson's, you get autonomic neuropathies, and so you do get constipation. and you do get bladder retention because of a hypotonic bladder. Yeah, so that's kind of the list of where you would do post-void residual urine. To be honest to gosh, in my clinic, I really don't have time to think about all these things. And so I end up doing the bladder scan regardless. And that's just the honest truth of, medicine today, that you have to just kind of keep moving forward. So that's why we end up over testing, because we don't have enough time to think about, what the probability is of the test being positive or not. Next slide. So I mentioned that urodynamic testing has kind of fallen out of favor, but it can be helpful in some cases where you're not making any progress on reducing urinary incontinence, particularly if you've tried something empirically with medication. Okay, next slide, please. So the stepwise approach towards managing urinary incontinence is lifestyle changes, leading then to behavioral therapy, and then consider thirdly, drugs, and as a last resort, surgery. And surgery may include, for women, resuspension of the uterus, to reshape the anatomy. And there's also surgical implants now that can be used to help contract the urethral sphincter. Next slide, please. So some of the weight loss, lifestyle changes include weight loss. It's particularly effective in the 65 to 74-year-old age group. Less evidence when people are older as to whether weight loss makes any difference. I mentioned about the individual that's taking 10 bottles of water a day. So if you find that person, you might want to have them kind of go down to 6. Caffeine is a real biggie. People who drink 8 to 10 cups of coffee a day, they're real candidates for being over caffeinated and predisposing them to bladder issues. And then the alcohol. Remember the 2-for-1 rule, that basically 1 drink equals 2 drinks in the older adults. And then lifestyle changes. This is not actually in the literature, but elevating your feet 1 hour before bedtime certainly makes physiologic sense to help reequilibrate the water that accumulates in the lower extremities. And finally, smoking cessation is highly recommended. Next slide, please. And then in terms of behavioral therapy, these are where you go through pelvic muscle exercises, and those are the Kegels. So it takes 4 to 6 weeks for the Kegels to kick in, and it's both valuable for both men and for women. And then this is kind of an important point. In previous years, we used to call it scheduled toileting, but actually now the terminology is prompted voiding, which actually is the same as scheduled voiding, with the addition of somebody goes and says, we got to go to the bathroom now, as opposed to saying it's time for you to go to the bathroom. So you actually want to physically take the older adult and get them to the bathroom. So that's called prompted voiding. Next slide, please. In terms of bladder training, so you're trying to suppress that sense of urgency. And so the idea is that what I mentioned before is that you want to just kind of freeze frame it. Don't run to the bathroom right away. When you feel like you got to go, you do your Kegels at that moment. And then when that sense of urgency subsides, then you can go ahead and go to the bathroom. And again, this takes weeks. And like I say, the Kegels don't kick in. And any type of muscle training exercise on general principles takes a minimum of 4 weeks to be effective, whether you're doing weightlifting training, bladder training, or otherwise. Next slide, please. So some additional considerations for bladder training, so that whether you need to go or not, you do frequent voiding to try and keep a small bladder volume. Every 2 hours or so, keeping a bladder diary and seeing how much urine you produce between those also would be another way to document your training. And then once you get into that 2-hour schedule, then you try to broaden it to about 3 hours, and you try to find the right balancing point between going to the bathroom too many times, which a lot of times is inconvenient, versus the actual episodes of incontinence. Okay, next slide, please. So it's important to consider the demented patient. And again, only prompted voiding is proven to be effective. So that's where you physically lead the patient to the bathroom and say, please go pee now. And so the idea is that the caregiver will monitor the patient, encourages them to let you know when there's a need to go to the bathroom, and then there's a prompt through a regular schedule of every 2 to 3 hours. As you can imagine, in the long-term care setting, if you had 200 patients that were going every 2 to 3 hours, that's a lot of patients or a lot of residents, right, that you need to sit on the toilet or get to the urinal. So that's not always practical, but that's the recommendation. Okay, next. Thank you. So the Kegel exercises are effective for all types of urinary incontinence. And so the issue, though, is that you have to have a patient who can remember to do those. I mean, you can still do them in the demented patient, although you'd have to somehow monitor whether they're getting an adequate squeeze around the perianal perineum area. So sometimes you can do that. It's just a little awkward because you got to put your hands on where the sun doesn't shine, and see if there's any contractions there. I suppose you could use some biomonitors, but that just seems way beyond the bucket, to be able to do that. So the Kegel exercises are, you squeeze down. You're almost trying to like pull up your outsides into the insides, right? And you want to hold that for 6 to 8 seconds and repeat those. So you do repetitions. And if you can do 3 sets daily, that's perfect. So like if you're even sitting at for people that are just sitting, either watching TV or even working, you can do these Kegel exercises, and they need to be done at least 3 to 4 times a week, and to persist. I mean, it's pretty much you got to do them all the time. Next slide. So that leads to the question of medications, and quite honestly, I've not had a lot of success with any of the bladder contraction or anti-contraction medications. Just have to be careful, as the disclaimer in the second point there. People with glaucoma, particular narrow angle glaucoma as opposed to open angle. People that have, and diabetics, gastric emptying problems, regurgitation, as well as people that have a history of urinary retention, usually those that have stroke in particular. So it's really a combination of things. You want to try to increase the bladder capacity. And again, that's a lot of, with the biofeedback and the Kegel exercises and so forth. So these medications do not stop the bladder contractions, right? They're just, that was the theory originally, that they reduced the number of contractions. Remember, I was talking about the urodynamic testing. That why do them? Because you're always seeing these contractions. Well, then they found that when they put people on the medication, they still had the contractions. So obviously these medications, they do reduce the number of incontinence episodes, but not, like I say, dramatically. Okay, next slide, please. Here's the list of all the possibilities. You got patches. I don't know. I don't see any sublinguals. But they all have the same, pretty much same mechanism of action, and some are more expensive than others. An important point is that all these agents are pretty much anticholinergic, although some people will claim that some of them are less anticholinergic than others. They still run the risk of that increasing the anticholinergic burden, which can cause confusion in the older adult. Next slide, please. So because they're anticholinergic, they have issues with dry mouth. In the demented patient, they can make the cognitive impairment worse. And if somebody has minimum cognitive impairment, that also can be worsened. And so if somebody is on Aricept, you don't want to add a anti-muscarinic bladder medication because it's going to potentially increase the memory impairment. Next slide, please. Mirabegadron, it's a somewhat of a newer medication. It doesn't act it's more of a beta mechanism as opposed to muscarinic. And its usefulness is in the demented patient, but you have to be careful because it may cause an increase in blood pressure, and it has a lot of drug-drug interactions. And a lot of people are on metoprolol for their blood pressure. People are on SSRIs, just another drug-drug interaction is the cough medicine with dextromethorphan. Okay, next slide, please. I have no experience. I can't really say about this off-label use of duloxetine for stress incontinence. We do use vaginal estrogen. It's pretty benign use. And then there's a bunch of other medications that have been cited in the literature that are not recommended. One of the points there is nonsteroidal anti-inflammatories at the very bottom. And in general, you want to avoid nonsteroidal anti-inflammatories because of their harsh impact on kidney function. Next slide, please. So there are some procedures that you can do. There's the sacral nerve neuromodulation. So that's an implantable device. Some people will use Botox for urge incontinence, and again, that is meant to reduce the bladder contractions. And then certainly I mentioned previously about the use of a pessary. So if somebody has that vaginal seal on the gynecologic exam, then you might want to prescribe. And the pessaries are fitted with a gynecologist. Next slide, please. So I mentioned about the suspensions interventions with surgery. Those last a couple of years and then they fail. So that's part of the problem is that, you might get some relief for a while, but then it just causes, it doesn't sustain itself. Next slide, please. So just to summarize, and then we can ask some questions, is that we've got a lot of 1 out of 4 individuals that are older that have urinary incontinence of some form. It's related to age-dependent changes and some disorders associated with chronic conditions. We want to do a good physical exam that includes observation of stress incontinence when somebody coughs with a full bladder and they leak urine. Next slide. And our treatment is stepwise. So we try to do both, the Kegels first, the behavioral changes, scheduled toileting, prompted voiding, other lifestyle changes, reduction in alcohol intake, weight loss, and then moving stepwise forward to medications and possibly surgery for refractory cases.